Thanks, Yoga, for taking us through the challenges with respect to both CMC and GMP. Now, next in the line, I have my dear friend, Professor Vijay Patil. I think he's the only clinician currently in this room who actually gave advanced therapeutics and CAR-T therapy to the patients. So to complete the loop, we have invited Professor Patil, who will take us through the nuisance of who is actually eligible for this advanced therapy from patient's perspective, and how to take care of when actually the product is in the market and clinicians are going to use it. Professor Patil is having a MBBS from GS Medical College, my batchmate of MBBS, MD from PGI, and then DM from Tata Memorial. Distinguished researcher, more than 700 publications to his credit. Currently, he is working both at the PD Hinduja Hospital and Sun Cancer Research Institute, where he is giving the advanced therapeutics to the cancer patients. And also his interest is to mentor the new upcoming oncologists. So over to Professor Vijay Patil. Thanks.
If I can have my slides here. So what I would do in the next 10-15 minutes is give a physician's point of view, what we look at when we are looking at the patients. Now, when we talk about who benefits from CAR-T, there are three things which we look at. One is which kind of tumor the patient has. Not every tumor benefits. What should be the fitness of the patient, and also is important where the CAR-T is given to the patient, and the skill set of the physicians who are giving this, and that is also equally important. And I'll also touch upon, when we do this, what the roadblocks in India are. So at very high level, what is CAR-T? Some of you may know of it, some of you may not know of it. So I'll tell you in a very simple language. All of us who are sitting here, daily at least 2 or 3 mutagenic events are happening in our body, and cancer is trying to develop. It is our immune system which clears the cancer. In spite of such an efficient immune system, few fellow human beings still get cancer. The question comes is why they still get cancer. It's because the immune system cannot clear this cancer. Now, why does someone's immune system cannot clear the cancer? That's because the immune system cannot identify the cancer as cancer. It identifies the cancer as a self-pain. So how does a immune system, the question comes, identifies cancer as cancer? The immune system identifies cancer as cancer when there is a unique antigen on the cancer. And there should be an reciprocal receptor for that antigen on the immune system, then only it can identify that cancer as cancer. And when we say CAR-T, we are trying to develop a chimeric antigen receptor. So we are just trying to develop a receptor over the surface of the T cell, which will enable the T cell to identify cancer as cancer, and then the immune system will take care of this cancer. That is a simple thing which we are trying to do. How it exactly is done by the clinicians? You have to see for the fitness of the patient. Please understand that at present CAR-Ts are used in patients not in first line, not in second line, but second line and beyond. So all these patients had advanced cancers, and they have failed multiple lines of therapy. They may have also failed transplants, and then the patient is coming to you. So the fitness of the patient becomes important, and I'll come to that in a few slides. What we do is something called leukapheresis. If some of you anytime have donated platelets, you may know there is a pheresis machine in which the blood goes into the machine, it rotates it, takes the particles which are required, and the rest of the blood comes back. In the same machine, you can do a pheresis looking at the for the mononuclear cells. Practically, we are trying to collect the T cells of the patients. These T cells are then sent to the GMP lab, where transduction is done and the CAR-T has been made, and then it comes back to us. Now, when these CAR-Ts come back to us, these are nothing but modified lymphocytes, and they are in millions of numbers. Now, we don't have that much space in the body of the patient that they can be directly infused. So we need to give something what is called as lymphodepletion chemotherapy, and it's a pretty high dose of chemotherapy needs to be given to the patient so that the lymphocyte count inside the body is reduced. This also helps in proliferation of CAR-T and makes the environment more inducive for the CAR-T to proliferate and kill the cancer. Now, this is one of the problems. These patients have been treated with multiple lines of chemotherapy prior, and when you give the lymphodepletion chemotherapy, which commonly we use is something called as fludarabine and cyclophosphamide, and they cause quite sustainable lymph suppression for these patients. And during this period, the patient needs to be in isolated HEPA-filtered room, something like a bone marrow transplant setting. Now, most of the CAR-T products which we use today are single infusion. And after the infusion, the patient gets discharged on 15th or 28th day after the complications are over. But after that, also for 6 months to 1 year, there are multiple complications which can creep up, for which both the physician and the patients have to be ready and vigilant. Now, up till now, we have got the CAR-Ts which are in lymphoma and multiple myeloma FDA approval, CD19 and BCMA CAR-Ts. Now, what would be of interest to you to know that these two cancers for India form only 1 to 2% of the patients. And those of you who are dealing with these cancers will know that the routine success of chemotherapy and transplant in this is fairly good. So we are talking about 2% of the whole cancers, out of which 60-70% will be taken care by the conventional therapy. Only 30% of them which would be falling in this bracket of those who are CAR-T eligible. Now, what's important many times is that we always talk about lymphoma, but lymphoma is also a big bracket. It's not that all lymphomas can be treated with CAR-T. CD19 is expressed only on B-cell lymphomas, not on T-cell lymphomas. So T-cell lymphomas are out of this bracket. Second, there are something like indolent lymphomas, like follicular lymphomas and all, for which you don't need to go for such kind of therapies. Only certain types of indolent lymphomas like mantle cell or CLL, which can have the chances of transformation ahead, would be taken up for such kind of therapies, or aggressive B-cell lymphomas. Multiple myeloma, we don't have a CAR-T developed in India at present, but it's a wonderful target for CAR-Ts. Multiple myeloma by nature is a non-curable disease. We are just trying to control it. Now, this is the place where CAR-T, in few years, we might also start talking about cure when we use it. Now, this is important. What we talked up till now is the type of malignancy. So if the patient has a B-cell lymphoma aggressive, or a B-cell leukemia, or an indolent lymphoma which is not getting managed, or a multiple myeloma, he is a candidate for CAR-T. But he should be fit. There should be adequate organ function for the patient. What we mean by adequate organ function? His creatine clearance should be about 60 ml per minute. He should have a good ejection fraction. He should not have any uncontrolled comorbidities, and there should not be multiple infections which could hamper your process of doing the CAR-Ts. Interestingly, today, when you do the apheresis, and by the time the product comes, there are 2 to 3 weeks gap in between. The patient should not have such a rapid disease that you do apheresis and the performance status of the patient goes down. So you are actually selecting for patients who are not very, very aggressive. You want it to be that the disease should be able to be controlled with the current conventional treatment for at least 3 to 4 weeks. Because if the performance status is bad, this patient is not going to do well. In fact, you are going to do a disservice to the patient if you administer CAR-T to poor performance patients. Obviously, if they have uncontrolled infection, and this is a problem when you are dealing with aggressive lymphomas or leukemias, where you would have these patients having multiple uncontrolled infections, especially gram-negative sepsis is very common in India. So what you look at is a functional status of the patient. You look at whether the organ functions are okay, and it's very important that the patients have the caretakers who can take care of them during the CAR-T and after the CAR-T procedures. It's important that where it is done, the team of physicians is trained to do at least bone marrow transplants. And they have some prior experience with CAR-T, because it's not a very easy learning curve. There are multiple aspects we need to learn while doing CAR-T. It's important that it is not only the oncological team and hematological team. You need to have a good neurological team, a cardiology team, and a nephrology team also in the same center. And it's important, these are costly therapies. So financial planning for these therapies should not include the cost of the product and the treatment, but it would also include the cost of stay in that city where the team belongs. And you would be surprised, and we had done a study in Tata where we saw that more than the cost of the chemotherapy, it is the cost of the stay in Mumbai, which costs a lot for the patient. Now the team need to be prepared. I won't go into detail for a lot of acute toxicities. You are going to give fludarabine, cyclophosphamide, blood counts are going to come down, infections are going to creep. And there will be two words which you will keep hearing in every CAR-T lecture, CRS and ICANS, cytokine release syndrome and ICANN. And believe me, you cannot predict when they can happen. And they happen in the least expected time. And the team needs to be prepared, so much so that the sisters during the morning rounds and the evening rounds keep taking the CRS score and ICANN score to check that is he developing CRS or ICANS. Many times subtle things can be caught earlier. Important is why even after the discharge, when the counts have recovered, these patients, what you are doing, you're targeting CD19, which is on B cell. So what we give a rise to something called as B cell aplasia, which means the B cell count is going to go down, which means your immunoglobulin levels are going to go down, which means that a patient would be, after CAR-T, would be at risk if you do CD19 CAR-T of repeated infections. And that needs to be taken care of. Interestingly, few of these viral DNA changes have led to secondary malignancies also. The proportion is very small, 1.8%. At present, the risk to benefit ratio seems in favor of doing CAR-T, but these long-term monitoring of the patient also needs to be done. And obviously, these patients have to be vaccinated. Now, the more important is, are all Indian cancer centers ready for this handling? I'll give you a number. Bone marrow transplant has been there in this country from 1983. We need around, according to ICMR, anywhere between 50,000 to 60,000 transplants done in this country per year. Can anyone guess what is the number of transplants which are done in this country? Stem cell transplant? It's, according to the data, anywhere between 3,000 to 4,000. So we are talking about a therapy which was developed in 1983, and we are not even doing half of what is. In fact, we are not even doing 1/10 of what is required. And we are adding one more therapy which would require such kind of diligent handling of the patients, and more than the cost of the product and more than this accessibility, the accessibility to deliver this therapy safely is going to determine how we treat our patients into future. And that's what it said, economic and access. Cost of the product, cost of the stay will be one part, but access, that whether we would have such good clinical infrastructure at multiple places will determine. See, CAR-T is not like surgery, that the patient comes, 7 days get admitted and then goes home. Here the patient has to follow for 6 months to look at the side effects which are coming, and it would be the best person to manage is the team which has done the process. We also have to look at the supply chain, as it was very well pointed out. Are we ready that minus 180 shipments can be done? Whether they can be handled, whether they can, what if, and in fact, I'll give you one example. I can't tell you the name of the hospital from Delhi. I got a call yesterday that Vijay, we were supposed to infuse the patient today morning, and the patient has developed high-grade fever and the cells have come. What do we do next? Such issues are going to come. Have we thought about them? Have we made SOPs for them that where these cells need to be kept? As he rightly pointed out, if you thought the cells, after that there's no, you have to infuse the cells. Do we have the workforce and training? At present, even if you look at bone marrow transplant, only few institutes give such training. Where is this workforce going to come with respect to the doctors and the nurses? And how the regulations are going to play? And I'll tell you what I mean by regulation. I'm not talking about regulations of approval. See, when you do a trial, you do it in a very idealistic setting. You don't get idealistic patients in real life. Around 30 to 40% of your patients would have, like if you're going to do a BCMA CAR-T, kidney issues are going to happen to the patients. So your creatinine clearance are going to be low. Are we ready to infuse in that setting, or we are not going to hold on? These things would be required to be sorted out. We need to educate our peoples. I don't think one manufacturing would help. We would require regional manufacturing so that things can come. We need a lot of protocol and standardization which academia and doctor communities have to teach the patients. We need national registries so that we can come to know about what happened to these patients and how many of them developed second malignancies or untoward side effects, which may be missed when we look at institutional audit data. But when the national pool comes in, we might have better statistical powers to look at that. And obviously, we will need financial supports to be given to our patients. But I wanted to spend last 1 minute on this. We are way, way behind in CAR-T. BCMA CAR-T is not even available in this country, and already 8 years and 9 years follow-up data have started coming in Nature. 99% of our cancers are solid tumors, and most of them come in advanced stage. These are the targets which already have got good data and good phase 2 data which we are looking at. In fact, GD2 has a 5-year survival data in neuroblastomas, and B7H3 for diffuse midline glioma now has a 4.5-year data. When are we going to talk about these targets? Because these are the majority patients in our country, and at present, conventional treatments do not serve benefit enough for these patients. We need better planning with the industry, the scientists, and the clinicians. We have a high incidence of solid tumors, and 75% come in advanced stage. See, cost of biologic, if CAR-T becomes successful, is a one-time treatment. If you want to give pembrolizumab, it continues. There is no end to it. It continues. If you want to use any immunotherapy, it just continues. You are talking about one-time treatment. If I give an option to my patients, get admitted, one month treatment, follow for 6 months, then that's it. As opposed to coming for 2 years, for 3 years, for repeatedly for chemotherapies, the choice, many would be making this choice. We are sitting on very different cancers from what West has. Head and neck cancer is our problem. We are not going to get a solution for head and neck cancer from them. It is our academia, our industry who needs to focus on this. Even if the solution comes from them, it is going to be so costly that we cannot apply them. So it has to develop from here, then only it will be optimized, the cost can be optimized, it will be accessible. And if it develops from here and the trials are done from India, then only we'll get the environment where the physicians have been trained from the trial setting to how to treat the patient best. With that, I've taken 1 minute more, and thank you for your patient hearing.